Doug. Well, when you say those years, it's kind of sobering. I've been around for a long time. Not one of those guys. And I can't tell you how thrilled I am to be here. Thank you, Doug, and thank you, Sarah, who I was privileged to work with at the University of Michigan, for the invitation. It's great to be among friends, including my longtime mentor and colleague, Chris Uni. As he's reminded me many times, he's taught me everything I know, but not everything he knows. So I've still got work to do. I asked, am I on the screen? I'm coming up. I asked what you'd like to hear about, and what was nominated was cancer. So we're going to talk about lung carcinoma. And I hope that goes well with your dessert. We'll try to make it uplifting.
I'll take one too.
Comes up, you'll see a little slice of where I'm from. For those of you who haven't been down Arbor, this is often referred to as the big house. This is where we play Big Ten football, sometimes with the Badgers. Didn't work out so well for us in basketball this year, but we're on your side, headed to the Final Four. I have season's tickets in this stadium. I have only seen them once because I don't like crowds and I'm claustrophobic. So I mostly give the seats away, and people kept telling me what great seats they were, and I thought I should go see them. And I did, and I thought once was enough. This is the saddest slide of the lot. It's true. I have no relationships to disclose, but I am open to being conflicted if anyone would like me to pay. Anyone would like to pay me to think differently. I thought we'd try to do three things, and that's probably too many at this time of the day, but bear with me. The first thing I'd like to do is talk a little bit about the role of lung biopsies to triaging patients with advanced stage lung cancer to appropriate treatment strategies. And really, most of the excitement in lung cancer these days is around patients with advanced stage disease. Managing the patients who present with early stage disease is still a surgical proposition, and not much of that has changed. We'll talk a little bit about applying the results of special studies in the context of the importance of histology and triaging patients to care. And we'll finish by talking a little bit about molecular pathology from the viewpoint of a blue-collar surgical pathologist. So I will not try to pretend to be something I'm not. But I think it's important that we all understand the value of these very powerful technologies and what they offer in terms of our ability to think differently about opportunities for patients who heretofore have had a pretty hopeless disease. So that's the plan. When I was a resident, which apparently was a really long time ago, when you talked about lung cancer, whether you were a pathologist or an oncologist or a surgeon, you really were expected to do one thing, and that was divide cancers into one of two pots. They were either small cell carcinomas or they weren't. And if they weren't, there wasn't a lot of interest in exactly how you would parse that out. There have always been rules and criteria for making those separations, but they simply weren't of much value. Fred Hirsch, a very famous thoracic oncologist, in a review in 2008 said, historically, histologic subtype has not reliably been shown to have prognostic importance in advanced non-small cell lung carcinoma. So no one cared very much, but that has all changed, as I'm certain you're aware, as I'm certain has been reflected in your practice. And yet, the rules for making these classifications until relatively recently have been steady for decades. And you're familiar with these same basic categories that you learned about in medical school. Squamous cell carcinoma is still one of the carcinoma types with a strong affiliation with cigarette smoking. It has diminished in terms of its contribution to incident cases of lung carcinoma in the United States, now accounting for about 1 in 4 patients with newly diagnosed lung cancer. It's still more common in men than women, by about 3 to 1, and it is more common centrally than peripherally, but it certainly can occur as a peripheral subpleural tumor. And you know how to diagnose this lesion on the basis of routine histologic criteria. And I'm going to refer back to these criteria as we look at some of the evidence around the importance of making these distinctions, and remind you that the evidence accumulated around the importance of these distinctions was predicated on these rules, not the current rules. And these rules are that historically, in iteration after iteration of the WHO Blue Books, a carcinoma was a squamous cell carcinoma in the lung only if it did one of two things. It made keratin, and or you could identify intercellular bridges, these little tram tracks between cell membranes that correspond to desmosomes if you look at them under the electron microscope, and nobody does that anymore. Adenocarcinoma is where all the excitement has been. Adenocarcinomas, however, are still defined by historical rules in a pretty simple way. A malignant epithelial tumor that does one of two things, and perhaps both. Either it makes glands, and glands are hard to explain to non-pathologists, but pathologists mostly get it. Tumor cells, usually columnar cells, that have specialized connections at their apices so that they can make spaces that are related to the ability of the cell to create secretions, and those secretions in the case of an adenocarcinoma are mucin, either seen as an apical secretion in columnar cells or perhaps as some sort of intracytoplasmic vacuole as in signet ring cells, and often that mucin is also present in the extracellular space. So the rules are simple. Squamous cell carcinoma, keratin, and/or intercellular ridges, adenocarcinomas, glands, and/or mucin. But defined in that way, in fact, adenocarcinomas have a broad range of histologies, which is part of the challenge of adenocarcinomas of the lung. The histology overlaps with adenocarcinomas from many, many sites. There's nothing unique about the histology in most circumstances that would identify these as originating in the lung. They show growth patterns that we describe as acinar, solid, and in the case of a solid tumor, you recognize it as adenocarcinoma historically by its ability to make mucin. Bronchial-alveolar carcinoma, a term that is waning in popularity, and we're going to talk a lot about that, defined as a tumor in which the neoplastic cells have this peculiar propensity to grow along the surface of lung structures, and then papillary carcinomas, and today we might add micropapillary carcinomas, which will no doubt be included in the next iteration of the WHO Blue Books. But in truth, historically in resected tumors that were well sampled, most adenocarcinomas didn't show just one flavor of architecture. They showed multiple flavors of architecture, indeed mixed tumors accounting for greater than 90% of resected lesions. And the language around adenocarcinoma shifted dramatically in February of 2011 when this paper was published in the Journal of Thoracic Oncology. It was called a concise review at 41 pages long. So thank God we didn't have the long version. A lot of authors, if you look carefully, you may be there, I don't know. But this really changed everything. But I would remind you that this is really a proposition. It's not a document of truth. It's a document of mostly expert opinion, and we'll talk about the strength of the evidence a little bit. And yet it has value. Oftentimes evidence is built in response to proclamations for which the evidence may at first be weak. But the focus of this paper, and it had several areas of interest, but the real focus, the one that has impacted practice, at least in Ann Arbor and I'll bet in Milwaukee, is the language around early stage well-differentiated lesions, where what might historically have been included in the category of bronchial-alveolar carcinoma are now subdivided, or at least proposed to be subdivided, into adenocarcinoma in situs and this new category of minimally invasive adenocarcinomas, and both of those categories can come in non-mucinous and or mucinous flavors. So to really understand the impact of this proposal, you have to go back to bronchial-alveolar carcinoma, which is the term that these are proposed to replace. In truth, for 2 iterations of the WHO Blue Books, bronchial-alveolar carcinoma was already arbitrarily defined as adenocarcinoma in situ. When that change was made in 1999, it was really a theory. There was no evidence that that was the right place to put the set point for separating bronchial-alveolar carcinomas from other carcinomas. But be that as it may, in the last 2 iterations of the WHO Blue Books, bronchial-alveolar carcinoma was defined in this way: growth of neoplastic cells along pre-existing structures without invasion. Without invasion of the stroma, without invasion of the vessels, without invasion of the pleura, and yes, it comes in non-mucinous, mucinous, or mixed types. The non-mucinous type is thought to be derived from Clara cells and or type 2 pneumocytes. The mucinous cells, I'll show you in a moment. And you've all seen these. You see them regularly, I suspect. At low magnification, you see overall preservation of the lung architecture. That's most easily appreciated, I think, at the periphery of these tumors, where you can see the junction between neoplasm and non-neoplasm. And there isn't much difference in terms of the essential integrity of the fabric of the lung. The difference is that along these thickened interstitial structures, you see a population of neoplastic cells, seen here at higher magnification, which makes them look more atypical than they might otherwise look at your scope. Clearly, you would recognize these as malignant, and here you can see the junction between abnormal and normal, and you can appreciate perhaps that these cells are growing along intact alveolar septa with no evidence of invasion, at least to the extent that this field is representative. So the thinking that bronchial-alveolar carcinomas are in situ carcinomas is not new thinking. That thinking has been established since 1999 without evidence. And the non-mucinous variants are the ones most likely to present in low stage, although either type can. So the non-mucinous bronchial-alveolar carcinomas, adenocarcinomas in situ if you prefer, are more likely to present as smaller peripheral and often subpleural lesions. Mucinous subtype defined in exactly the same way, but with different cytology. Tall columnar cells with varying amounts of cytoplasmic mucin, and then the rest of the words are the same. And again, you've seen these at low magnification. The message is the same. The architecture of the lung is preserved. The problem is this population of cells. And the challenge with the mucinous variants is these cells don't obey the rules when it comes to the signals that pathologists rely on to separate malignant from benign. The NC ratio is low. The nuclei look pretty uniform. They often don't have very vesicular chromatin, which is why these are often overlooked on the basis of cytology samples alone. It's not uncommon for me to receive small biopsies of mucinous bronchial-alveolar lesions in consultation because it's hard to pull the trigger on cancer for something that looks so benign. But the bottom line is there is no differential diagnosis for this phenomenon. There is no circumstance in which you see benign, non-neoplastic columnar cells growing as a uniform population of columnar mucinous cells without cilia. That has to be malignant. And this is the subtype of bronchial-alveolar carcinoma more likely to present at an advanced stage, more likely to look like some sort of non-neoplastic consolidating lesion on imaging studies, more likely to present with bilateral disease. So the first recommendation that came in the February 2011 paper was that they recommended discontinuing the use of the term VAC. For all of these recommendations, the recommendations are qualified, and most of them are qualified as strong recommendations based on low quality evidence. And what's interesting to me, and I think it's a phenomenon in all of medicine for reasons unclear to me, this quickly became the standard of care. And I don't know when the bar got that low, right? Strong recommendation based on low quality evidence sounds to me like reckless behavior, right? Like I don't even know what to do with that. But it has absolutely been adopted as the standard, and now some of the evidence around some of these recommendations is accumulating. We're going to work back to that. So the reason there's low quality evidence is this is just a recommendation that you change the way you use the language, and there isn't much evidence about which term is a more effective communicating vehicle. So in our own practice, I think this is really a local decision. I don't have strong feelings one way or the other. I think what is important is that when you speak with your clinicians, who are really the primary consumers of your language, that they understand what you're saying. So what we did when this came out, and I think you were there at the time, we contacted our thoracic oncologists and said, do you want us to adopt this terminology or not? And they said, no, we're not fans. At the Mayo Clinic at the very same time, when we talked about this paper in our journal club, they said their clinicians wanted them to adopt this terminology, so it's become the terminology they use at the Mayo Clinic, and I don't think one is more right than the other. Now this really gets to the meat of the primary recommendation in the paper, which came in the form of recommendation 2, which was that for small tumors, defined as those 3 centimeters or less, so you're on your own when they're 3.2. But for small solitary adenocarcinomas with a purely lipidic growth pattern, the growth pattern we're talking about, distribution of neoplastic cells along intact interstitial structures, the recommendation is that you use the term adenocarcinoma in situ that defines patients who should have 100% disease-specific survival if the lesion is completely resected. Strong recommendation, moderate quality evidence. Now, recognize the moderate quality evidence is the evidence that patients with this lesion have a good survival. It's not evidence that this term is a better term. The evidence is that patients with tumors like this, whatever you call them, have a good prognosis, and that's true. And that has moderate quality evidence, which, by the way, is as good as the evidence gets in this paper, which is not a criticism of the paper. It's a comment on the state of the evidence in the business we're in. And the evidence for this comes from all sorts of sources. Most of it was generated early in Japan. Now there's evidence in North America and Europe to support this recommendation in terms of recognizing that patients with small, non-invasive lung cancers have virtually 100% disease-specific survival if you treat them appropriately. And so this is an example of the sort of evidence that leads to that recommendation. This is data that came from Japan for somewhat smaller lesions, so these are less than 2 centimeters in size, small lung cancers. And they graded them. Grade 0 meant kind of purely defined adenocarcinoma in situ, or BAC, whichever term we prefer. Grade 1 were those that mostly looked non-invasive but had a little area of stromal invasion in the viewpoint of the authors. For me, these are the ones where you probably wouldn't agree with each other on whether there was invasion or not. You know, it's the sort of case you take next door to your neighbor and say, I don't know if this is invasive or not, what do you think? And your neighbor, maybe Sarah, would say, yeah, I think it's probably invasive. And you go back to your office and think, well, gosh, I don't know, is she right? I want to be right. So I'm going to go show it to somebody else. You show it to somebody else, they I wouldn't call it invasion, and you're stuck, right? The good news is you'll learn it doesn't matter, right? So if somebody sends me that question in consultation, I think about it for a little bit, not too long, make a decision and move on, because it's not going to matter much. Grade 2 were tumors, and you've seen these, tumors that have a central elastotic scar, often up next to the visceral pleura. This in situ or bronchial-alveolar growth pattern at the periphery, and their grade 2 tumors were ones that had a little bit of invasion at the periphery of that scar. And again, I suspect these are tumors where there would be low rates of inter-observer agreement. And grade 3 tumors were ones where everybody would agree this is invasive cancer. No disagreement. And as you might have guessed, whether it had little or no invasion, they had the same beautiful survival, and a lot of invasion on which everybody could agree was really the pivot point. This has now been studied again by multiple groups. This is data that came from NYU, where they looked at 141 consecutive surgical resections for low-stage disease. They divided them into groups, but defined a little bit differently, but still focusing on how much invasion. So their group 1 were kind of a strictly defined bronchial-alveolar carcinomas, what since February of 2011 you might prefer to call adenocarcinoma in situ. Group 2 had a little invasion, defined here as no more than 5 millimeters in size. So there's a nice figure in the paper showing, a line drawn where the tumor is and a line where the invasion is, and the invasion should be no more than 5 millimeters. Group 3 was more than 5 millimeters, and Group 4 was only invasive cancer, no bronchial-alveolar component. And just like the Japanese study showed that whether you had no invasion or a little invasion, here defined as less than 6 millimeters or no more than 5, no patients died of their disease. Alan Borchek and colleagues showed exactly the same thing in data from Columbia. And so it's pretty clear that a little invasion does not change the survival advantage in low-stage bronchial-alveolar carcinoma. And this is really the group of tumors for which the term minimally invasive adenocarcinoma was proposed. Now, I would argue you could take this same body of evidence and come to kind of a different conclusion about how we should use the language. So being something of a minimalist, in 1999, when the WHO arbitrarily declared that the term BAC should only be used for purely in situ lesions, I thought that was a little harsh. I thought, well, I bet a little doesn't matter. So as this data was accumulating, I thought, this is great. So now we'll redefine BAC as something that can have a little bit of invasion, but not too much. But since we like subcategorizing, instead we created a new category, minimally invasive adenocarcinoma, that is biologically identical to in situ disease or bronchial-alveolar carcinoma. The recommendation is for small, that is no more than 3 centimeter solitary adenocarcinomas with mostly a bronchial-alveolar growth pattern, and small foci of invasion, meaning no more than 5 millimeters, we recommend a new concept, it's not a new concept, of minimally invasive adenocarcinoma to define patients who have the same survival expectation as patients with purely non-invasive tumors. Again, a very strong recommendation on low quality evidence. The problem is, if you have those conversations with non-pathologists, this sounds really easy. I mean, how hard can it be? All I want you to do is tell me if there's invasion or not. I mean, we pay you to do this. And then get out your ruler and tell me how big the invasion is. This should not be hard. But we know that it's hard. And in fact, the WHO says, look, the distinction between invasion and non-invasion may be difficult. Actually, these photomicrographs are of a case that I presented at our annual Surge Path course that we have in Michigan, and I presented it as a nice case of what I thought was bronchial-alveolar carcinoma with a scar. Gave me an opportunity to talk about adenocarcinoma. At the high magnification view on your right, you can see that in the midst of that scar, there's epithelium that is neoplastic. You can also see there's alveolar macrophages in the air spaces. And if you look at enough scarred lungs, you know this is common. I mean, in lungs resected for non-neoplastic disease or biopsy for non-neoplastic disease in which you happen to get a scar, whether it's an apical cap or something else, it's very common to see entrapped non-neoplastic respiratory epithelium in the midst of the scar. And so it's not a surprise, I don't think, that if you have a tumor growing along the scaffolding of the lung, it can find its way into those air spaces, and that may not mean invasion. So I was very happy that this was a non-invasive tumor. When I was working with my mentor, Dr. Katzenstein, to put together cases for the 2011 USCAP Long course, we wanted to talk about this evolving terminology about adenocarcinoma. I said, oh, I have a great case. It would be great. We can use it. I sent her the slides. She called me up and said, that's a great case of invasive adenocarcinoma. I think we should use it. I thought, well, hell, I have to find another case. So I was thinking about this after February of 2011, and I got a case in consultation that was a small tumor, 0.8 centimeters. And I thought this would be a handy case to have the dialogue, because given that the threshold for minimally invasive or not was just 6 millimeters, you'd kind of have to see this tumor as all or none in debating the issue of in situ or not. You follow me? I mean, it's almost at the threshold. And I was looking at this case, kind of thinking about this terminology, and I thought, you know what I'm going to do? I'm going to send pictures of this tumor to the members of our journal club. So we have a monthly journal club. Sarah has participated in our journal club. In fact, when she was our fellow, every month that I had to do it, she did all the work. It was great. And this journal club is one that we do with multiple institutions, all 3 Mayo Clinic sites, University of Vermont, University of Calgary, University of Michigan. And we have about 15 pulmonary pathologists. It's their area of academic interest. They spend hours and hours doing pulmonary pathology, and this is the area in which they publish, so I think they would qualify as experts by any definition. So I sent these images of this consultation case to my 15 or 16 pulmonary pathology friends, and this was lifted right from my email. It was a simple question. Would you classify this as in situ, minimally invasive, or invasive? Simple question. So here are the exact images that I sent. This is the lowest magnification image. You can see on the most right-hand side non-neoplastic lung. And you can see there, the thing I liked about this case is there were very prominent, lightly pigmented alveolar macrophages. So to me, that really provided a simple roadmap to see intact air spaces. And you can see that everything changes in the rest of the field. Where the lung looks basically intact, you can see these alveolar macrophages throughout, but clearly something is amiss. And at higher magnification, you can see that there's this population of atypical cells that seem to be sprinkled along, at least to me, intact alveolar structures. Alveolar spaces contain pigmented macrophages. Here they are at higher magnification. I don't think you'd have to think too hard about whether it's malignant, except that it's so small. That was really the dilemma with this case. Should I really call this cancer? Was the contributor's dilemma, and I understood it completely. Elsewhere in this lesion, you can see very clearly that the lung's architecture was preserved. Here's a very nice bronchiole with its companion vessel. You can see the airspace macrophages. So before I show you the responses I got, you're going to have to participate. Unfair, I know, after a long day, but after all, you've had dessert. So how many would call this in situ adenocarcinoma? Looks like half the room or better. How many would say minimally invasive? Nobody. There's one. Invasive. So it looks like the distribution of votes is in situ, invasive, minimally invasive, something like that. Here's what the expert panel did. 3 in situ, 3 minimally invasive, 9 invasive. I was stunned, to be quite honest. I was stunned. For the 3 who said minimally invasive, I answered all of them and said, which part's invasive? And they were very irritated with me. You know, I played along, I answered your question, and I don't have to answer that one. I got all sorts of interesting comments. I thought this one maybe made the most sense. You know, it's hard. I'd show it around. But I think it speaks to the fact that this is hard. And now there's evidence accumulating around how hard this is. This is a paper that looks specifically at the issue of invasive or not invasive. Most of the papers that have been showing up now around this classification scheme have really focused on the ability of pathologists to agree on the assignment of these different patterns. But not many have really looked at invasive versus not invasive. So this is a paper that looked at invasive versus not invasive. And I would argue that the odds were stacked in favor of getting a good result. Because for each patient, they only had 2 static images per case. Right? So you know that's better than real life where you get to look at the whole slide. That creates opportunities for disagreement. But if the photographer chooses the 2 fields you get to look at, right, they're going to bias you to see what they see. The contributors said, you know, I think they predicted that 20 of these were straightforward, typical invasion. 24 should be straightforward, not invasive. 24 might be problems. They were scored by 28 international experts. It's interesting because if you look at the number of expert pathologist authors, there are 30. So I don't know the 2 that were thrown out. There you go. And they scored them on a 5-point scale. At the extremes were 1, definitely invasive, and 5, definitely not invasive, and then, you know, room to hedge in between. But the extremes, invasive, no invasion. And here's what happens. So each of these columns is a case, and that's kind of hard to look at, I suppose, but if you kind of follow one case, you can see that there were many cases where the range of opinions went from invasive to not invasive in about equal numbers. So experts in equal numbers saying definitely invasive, definitely not invasive, just like the N of 1 that I showed you, that I sent to our journal club. And in fact, if you look at the kappa statistics, they were awful. I mean, you cannot use that for real work. Right? I mean, you wouldn't get on an airplane with those kappa statistics. How do your pilots do? Pretty good. You know, our kappas are maybe 0.2 or less on how we ought to land this thing. But I don't think you should worry. And, you know, the authors said, well, this is an issue of education. This is a new idea. More precise definitions and better education are required. But 50% of the participants were authors of the white paper, right? So my thinking was, well, I mean, should you know the rules before you proclaim them? I mean, so I'm not buying it. I'm not buying that the problem is education. I think the problem is that this is hard. It's hard to know whether these are invasive or not. This is a paper from the University of Maryland where they were applying the new terminology. They had 3 adenocarcinoma in situs, 8 that were minimally invasive, 19 that were lipidic predominant but invasive adenocarcinomas. As others, they showed that these got bigger as they kind of moved along the invasion spectrum, and that there was an impact on survival as well as the likelihood of lymph node metastases. It was a very compelling paper that showed that this classification scheme worked. This was figure 4, and we talked about this paper at our journal club. And I'll just poll you as we polled ourselves. Let's just walk through these images. Does not change the survival advantage in otherwise low stage bronchioloalveolar carcinoma, whatever you call it. But it can be really hard for even expert reviewers to agree on the presence or absence of invasion, much less the size of the invasion. So I think the problem is in applying the principle, but I think the principle holds. Well, let's set that aside. So that's one set of challenges. But we have clearly embraced the idea that histologic subtyping is important. And in this guideline from Canada, the authors say there's strong evidence that histologic subtype is predictive of treatment efficacy and or toxicity. And I think if you were critically grading the evidence, you probably wouldn't call it strong evidence, you'd call it moderate quality. But But if you really work back to the evidence, there is some evidence that subclassifying tumors, that is separating squamous from adeno, is mostly what we're talking about, that has some value. But the evidence is perhaps not nearly so strong as you might assume it is, given the level of passion with which we now say is critically important. So for example, this is almost the entire evidence that says Avastin is a dangerous treatment for squamous cell carcinoma. A little bit of evidence has emerged since, which is no stronger. And this evidence came from a phase 2 trial in which 99 patients were treated with either placebo, low-dose Avastin, or high-dose Avastin. And 6 of those patients experienced life-threatening hemoptysis or hematemesis, 4 of which were fatal. And this is the paper that led people to say, you must have heard this, that you can't give patients with squamous cell carcinoma Avastin or they'll bleed to death. Have you heard that? Right? That's when you're in college, it says, I have to know, right? This is why they have to know. Well, here are the facts. Of those 6, 4 were squamous, 2 were adeno. 5 were cavitated on imaging studies, and they were all central tumors. And interestingly, 5 of the 6 were on the low dose, not the high dose arm, but that's neither here nor there. And the authors in the discussion actually said, we don't know if it's the squamous histology or having a necrotic central tumor that's the risk. But that's okay. This became kind of the mantra. There's better evidence, actually, as shown in this meta-analysis, that separating adenocarcinoma from squamous cell carcinoma is important when you're choosing combination chemotherapy for these patients, not targeted therapy. So pemetrexed, CP, if you will, is more efficacious in patients with adenocarcinoma and large cell histology, which is probably mostly poorly differentiated adenocarcinoma. And gemcitabine is a more favorable drug for squamous cell carcinoma. So this is meaningful and is perhaps the greatest reason that there's value in separating adenocarcinoma from squamous cell carcinoma. Now we're going to return to the fact that all of this evidence was generated using the old WHO rules, no immunohistochemistry. So this is evidence based on the old rules. And what nobody knows is what the evidence will be based on the new rules. Nonetheless, a very reasonable recommendation that I think has become pretty standard practice, that for small biopsies in cytology, non-small cell lung carcinoma isn't enough without more work. You may end up stuck there anyway, but the recommendation is that you try to further subclassify these tumors into a more specific histologic type, mainly adenocarcinoma or squamous cell carcinoma whenever possible. Strong recommendation. Moderate quality evidence, but the evidence is not based on this recommendation. That is, that there's no evidence that immunostains have this value. But there's evidence that separating squamous from adeno have value. You with me? So that's where the evidence is. And you've all seen these cases. Here's an example in the upper fields. This was a consultation case from Florida, a poorly differentiated tumor on a bronchial biopsy. I suspect if we polled the room, we'd get different answers as we would in our group about whether that's likely squamous cell carcinoma or adenocarcinoma. And this is when you pull out the immunostains, right? I mean, it becomes, do you use immunostains for this problem in your practice? Pretty common. So I have to constantly remind our residents, as you know, Sarah, that the first thing you should do is actually look at the H&E. And that's actually becoming a dying trend. But I think you should start there. And actually, it can end there. I mean, if using the old rules, and this is true for many patients, you can make the diagnosis of small cell, squamous cell, or adenocarcinoma, in my view, you're done. And in fact, I would argue that doing more might get you in trouble, right? And that works out well for me because I get those in consultation. Because immunostains don't show 100% fidelity to what you would predict from the histology. Now, sometimes it's because the histology is misleading, and sometimes it's because the immunostaining results are unpredictable. So in that circumstance, there is no reason to do stains. And I think there's a lot less interest in that with the change in reimbursement around immunostains. So I think our enthusiasm is changing. This is where you need them, right? You need them when you can't tell. And I think in most practices now, this has become routine. I think in the early stages of the enthusiasm around the use of stains for biopsies, it might be at the request of a clinician, but now I would say in most practices, this is standard. And again, if you view the world through the lens of your oncologist, they think the world looks like this. Just do the stains and tell me how it turns out. And maybe you use 2, maybe you use 3, maybe you use 4, maybe you use 5. I don't know what you use. We tend to use 3. We tend to use these 3. And if the CK56 and the P63 is positive, it's a squamous cell carcinoma. If they're negative and it's TTF1 positive, maybe you throw in NAPS and then it's adenocarcinoma. The problem, of course, is that that isn't really how it works out all the time. Because if you look at the frequency with which these tumor types stain with these various markers, it's variable, and you can get discordant results. In fact, in this review of a large number of tumors, you can see that there's overlap between these categories. So there are adenocarcinomas that fail to stain for TTF1, and some of those are CK7 positive, and some of those are NAPSIN positive. So you don't always get a pure result. And the same is true for squamous cell carcinomas, here also using desmoid colon. So you can talk about the various sensitivities and specificities of these immunostains, but used in a panel, you have to sometimes use your judgment, and you can't start without looking at the H&E, or you may flounder. It turns out that there are, no doubt about it, TTF1 negative adenocarcinomas, and it's intuitively attractive to pathologists that that's more common in higher grade lesions. That as tumors become more poorly differentiated, they kind of disconnect from the predicted immunophenotype, just as they disconnect from other predictions about their histologic phenotypes, and no surprise that those TTF1 negative tumors, which are higher grade, may behave more badly. So whatever stains you do, this is where you do them, not for those where you can get there on histology alone. And if it's a good day and the stains do as they should do, you may be able to resolve this problem, and you could give the clinicians the answer that they want. So if we go back to the illustrative case that I showed you, here's how the stains came out. We have some nice positively staining internal controls. There's some benign squamous epithelium showing the strong staining for CK56. Tumor cells are negative. Same for P63. They're nicely positive for TTF1. They were also positive for NAPSIN, showing that very characteristic granular cytoplasmic staining. Be careful about 34-beta-E12. That's not the high molecular weight cytokeratin stain you want to use. That is a lot more promiscuous in terms of separating adenocarcinomas from squamous cell carcinomas, and many adenocarcinomas are positive, as was this one. And in fact, for P63 and CK56, a little bit of staining is not rare in adenocarcinomas. So the signal you're looking for is a strong diffuse signal to make these separations. And if you don't get those signals, it remains ambiguous. So the notion that you can now solve all these problems is actually not true. But what's also true is nobody yet knows whether this activity will have a payoff. So it's a hypothesis based on evidence generated with the old rules. And what we don't know is if applying these technologies to tumors selected because they're high grade and poorly differentiated will have the same impact. And again, if we go back to our February 2011 paper, the authors say, although we've made the recommendation, we acknowledge that it's unknown whether there's any added value in this activity. So time will tell. Well, that kind of moves us to the molecular age, which has been with us for over a decade in lung cancer. And it's really been the decade in which lung cancer has become very exciting and sexy. And I didn't know that would happen when I chose UIP as my topic of choice. But it's an exciting time. And the number of targetable mutations that you can identify in lung cancers grows by the month. We don't have a journal club where we don't add to the list. This is data that came from the Dana-Farber, published in 2012, where they looked at 419 patients collected consecutively. They were mostly adenocarcinomas. You can see wild type was still the largest piece of the pie. Biggest group of mutations was KRAS. Second was EGFR, and you recognize the other players. And in fact, we now have a guideline. The problem with guidelines in this space is they can't possibly keep pace with the science. But the guidelines that were published at the end of 2013, a joint effort by the CAP, the IASLC, and AMP, says that patients' lung cancer should be tested for EGFR mutation and ALK fusion gene before targeted therapy is given. So two specific targets now have become a standard expectation, many laboratories now test for more than these two mutational events. And notice it says before targeted therapy is given. So I think it's an individual practice choice of which patients you do the testing on. There are practices that now routinely do this on all adenocarcinomas. To be honest, in the language of lean, I think that would be overproduction or extra processing, because in many of those patients with low-stage disease, that's not an actionable result. In our own practice, this is done at the request of oncologists, and we're blessed, as Sarah may have told you, we have this aberration in Ann Arbor where we work with these magnificent thoracic oncologists who have all kinds of common sense. It's disorienting, quite honestly. And so we periodically ask them, do you want us to do this routinely? And they look at us puzzled, and Greg Galgarian says, no, because we can't use the information. It's like, wow, that's such a refreshing point of view. And the truth is, those who say, but you'll have the information in the bank for when the patient relapses, there's good evidence that when they relapse, you have to start over, because the fidelity of the mutations isn't great. So if you're going to treat them for recurrent disease, you can't depend on the primary to tell you what the targetable lesion might be today. So it's hard to make a strong argument for testing everybody up front. We don't do that. EGFR, hard to believe, is now kind of the grandfather of targetable mutations in lung cancer. The mutations of interest are those in the intracellular tyrosine kinase domain, and that is a place in which the mutations preferentially activate survival pathways. And there are two lesions that account for the vast majority of the pie, almost 90%. And most assays look for just those two mutations. Recognize that if you do that, you will miss some that are still potentially actionable. But the two mutations that most assays test for are single point substitution in exon 21 and an exon 19 deletion, which account for nearly 90%. So the recommendation in the guideline is that you do this analysis using some sort of sequencing assay. FISH, copy number variation, has a relationship to the likelihood of response to a tyrosine kinase inhibitor, but not the same power as knowing whether or not there's an actual sensitizing mutation. And histology, knowing that it's an Asian woman who never smoked with a bronchial-alveolar carcinoma, is insufficient. Because not all of those have EGFR mutations, and adenocarcinomas that defy those rules might have. So the truth is, the only way you know if an adenocarcinoma, or any carcinoma for that matter, has this sensitizing mutation is to do the test. There's growing interest in immunohistochemistry, which is not the usual antibody to the extracellular ligand, but new antibodies that are specific to the mutations in the intracellular kinase domain. And those are now under study, and those may eventually have a role. But the recommendation in the 2013 guidelines is that you do some sort of sequence analysis. EML for ELK, I like to remind our residents this observation was made in what was essentially a case report in Science, so you can still learn a lot from one patient, in which they discovered these novel inversions, meaning that both partners of this fusion are from the same chromosome, chromosome 2. And the ELK breakpoint for these fusions is very predictable, always happens in the same place, but the same is not true for the EML4 partner, which means that you have to think careful about your testing strategy, because if you're going to try to construct a probe set to recognize all the probabilities, that's a little daunting. So it's a perfect opportunity to use a FISH break-apart strategy, as I'll show you in a moment. Now, you'll often read that EML4 ELK mutations occur in about 5% of patients with adenocarcinoma. But the truth is, the frequency of this mutation, this fusion gene, is highly dependent on the patient population you study. This is some data that came from Brigham and Women's as well as MGH and the University of Pittsburgh. They looked at a surgical cohort from Brigham and Women's and University of Pittsburgh. These were consecutive patients operated on for adenocarcinoma. There was a total of 227 patients, and only one, less than 1%, actually had an ELK mutation. When they looked at consecutive patients referred to an oncology clinic for adenocarcinoma of the lung, the frequency of this mutation was nearly 15%. And in fact, if you take ELK positive patients and compare them to ELK negative patients, they're far more likely to have presented in advanced stage disease. So there's something biologically different about ALK-positive tumors and ALK-negative tumors, and so the frequency of this event is totally dependent on the population you study, which makes even more sense for doing this testing only on patients with advanced stage disease. It's a much less frequent event in early stage disease, and it's not actionable in that context. And while I think it's sometimes tempting for pathologists to be cynical about the value of these expensive observations, you can imagine if you were in a patient's shoes, they can be life-changing in multiple ways. Here's a story that really brought that home to me. This is a University of Michigan patient, 59-year-old woman, never smoker, had a 5-month history of progressive shortness of breath and cough. Over the period of that time, she experienced a 10-pound weight loss. On examination, she had crackles. On auscultation of her chest, she was hypoxemic on room air. That got worse with exercise. This is an image from her CT scan. This is some language lifted from her radiology report. Miliary bilateral nodules, right middle lobe and left lower lobe consolidation, right lower lobe infiltrate, bilateral septal thickening, not really cancer words. And in fact, the clinical suspicion was that she had some sort of diffuse non-neoplastic lung disease. When she underwent transbronchial biopsy to try to get a handle on her non-neoplastic lung disease, it was bad news. She had a well-differentiated adenocarcinoma with, in this small sample, a predominantly bronchial-alveolar growth pattern. Well, she had already been started on erlotinib before her molecular testing was complete. That was started on the 26th of October. But while she was started on that treatment, her tumor was being tested using this break-apart strategy for EML for ALK, where you have flanking probes around the predictable breakpoint in the ALK gene. The EML4 part is unpredictable, so you put flanking probes around the predictable breakpoint, and so when that signal breaks, and you get split probes, that's a positive signal. And if you get that in enough visualized cells, and this can be hard to visualize because they don't split very far, then that's a positive result. So here's her result, and she clearly had an ALK rearrangement positive tumor. And in fact, the recommendations from the Biomarkers Guideline Committee is that you do this with FISH. PCR is not recommended. I think in a research setting it can be very powerful. And immunohistochemistry is becoming more popular. They acknowledge that if it's carefully validated, you can consider that as a screening methodology to select specimens for ALK FISH testing, not unlike what you're already used to doing for HER2 in the breast. And in fact, this was proposed in an ALK testing algorithm published a few years ago, suggested that you can start with immunohistochemistry using the right antibody, the right detection system, that if it's negative, there's no reason to do FISH testing. If it's positive, there's no reason to do FISH testing, and if it's an equivocal result, that's probably the right place to use FISH testing. The problem with this is that none of the studies that have done this have used the same definition for 0, 1 plus, 2 plus, or 3 plus. So it's not standardized the way HER2 testing is done for the breast. So if you're going to do this, you have to do all the validation in your own lab. You can't take a cookie cutter off the shelf or in a kit. But be that as it may, on the 1st of November, 5 days after she had her first dose of erlotinib, her tumor was known to be ALK positive, and crizotinib was added to her regimen. Now, mind you, these are taken as a pill. So this is very different from the toxic infusions that has been the mainstay of therapy for lung cancer patients. So this is a pill, and they don't get very sick. 2 days later, her O2 saturations had improved to 95%. And a week later, she abandoned her oxygen. A month later, she was asymptomatic. No cough, no shortness of breath. And on January 25th, the radiologist declared her CT scan nearly normal. Now, cynics would say, well, that'll be short-lived. We know that these patients develop resistance. I would say, well, takes a non-toxic pill once a day, can breathe again, no cough, feels great, back to normal activity, and last I checked, 2 years out, she's still asymptomatic. Probably worth it. Probably worth it. Squamous cell carcinoma will be next. There is no question about it. This was an article in the New York Times, September 9, 2012, to being available in print. Dr. Bruce Johnson, pictured here from the Dana-Farber, said we're sort of where we were 4 or 5 years ago with adenocarcinoma. And what the TCGA study showed is that if you do a comprehensive mutational analysis of squamous cell carcinomas, over half have targetable molecular lesions for which there are available agents. And while it's a different landscape than adenocarcinoma, I think it clearly demonstrates the way forward. So while, as summarized in this review, our current state is to do these kind of one-off assays, I have no doubt that the future will be a different approach, which is why everyone's becoming interested in platforms like next-generation sequencing, where for each individual tumor you can develop a really comprehensive view of the tumor's profile at both the DNA, the RNA, and the protein expression level. Now, I would point out to you that in both of these diagrams, the first step is an H&E. Now, the problem with images on the right is that many people see that and say, oh my God, I chose the wrong discipline. I will soon be unemployed. No chance. I am very confident that especially in today's environment, where we're being asked to be good stewards of medical resources that we were fine with wasting in a fee-for-service environment, we're going to have to make good choices for the right reasons. And I actually think the role of pathologists will become greater, not lesser. Just my prediction. 10 years from now, you'll be sitting around drinking wine saying, you remember when that son of a bitch from Michigan said this was all going to be okay? What was his name? I'd like to give him a piece of my mind. Well, my hope is that after a long day and a great dinner, you can at least take away these three things. An evidence-based view of how the results of lung biopsies are important to triaging patients with advanced stage disease, to appropriate treatment strategies, the role that special studies can play in facilitating that triage, and the importance of molecular testing to managing patients today with adenocarcinomas, tomorrow squamous cell carcinoma, I suspect will become routine testing in all lung carcinomas. Thank you for your attention. To being available in print, Dr. Bruce Johnson, pictured here from the Dana-Farber, said we're sort of where we were 4 or 5 years ago with adenocarcinoma. And what the TCGA study showed is that if you do a comprehensive mutational analysis of squamous cell carcinomas, over half have targetable molecular lesions for which there are available agents. And while it's a different landscape than adenocarcinoma, I think it clearly demonstrates the way forward. So while, as summarized in this review, our current state is to do these kind of one-off assays, I have no doubt that the future will be a different approach, which is why everyone's becoming interested in platforms like next-generation sequencing, where for each individual tumor you can develop a really comprehensive view of the tumor's profile at both the DNA, the RNA, and the protein expression level. Now, I would point out to you that in both of these diagrams, the first step is an H&E. Now, the problem with images on the right is that many people see that and say, oh my God, I chose the wrong discipline. I will soon be unemployed. No chance. I am very confident that especially in today's environment, where we're being asked to be good stewards of medical resources that we were fine with wasting in a fee-for-service environment, we're going to have to make good choices for the right reasons. And I actually think the role of pathologists will become greater, not lesser. Just my prediction. 10 years from now, you'll be sitting around drinking wine saying, you remember when that son of a bitch from Michigan said this was all going to be okay? What was his name? I'd like to give him a piece of my mind. Well, my hope is that after a long day and a great dinner, you can at least take away these three things. An evidence-based view of how the results of lung biopsies are important to triaging patients with advanced stage disease, to appropriate treatment strategies, the role that special studies can play in facilitating that triage, and the importance of molecular testing to managing patients today with adenocarcinomas, tomorrow squamous cell carcinoma, I suspect will become routine testing in all lung carcinomas. Thank you for your attention.